plenty of questions, and before I go to the podium and do the polling for the CME class, I have a couple of questions. So maybe some of them I can ask very briefly when Michael is sitting. Julie, what about patients with CNS involvement? How will you approach this patient? We have many questions, quick answers.
Yeah, CNS involvement is always difficult. I would say definitely combination and agents that get into the CNS, rituximab containing BTK, all the things that potentially can get into the CNS, depending on the situation, age of the patient, comorbidities, et cetera.
Still a frontier. Wojciech, I think you mentioned your patients in the Nordic regimen. Do you think there's still a role for autologous stem cell transplant in mantle cell lymphoma?
Thank you for this question. Now, the role of stem cell transplant is decreasing. However, for the young patient with unmet medical needs, we do not have a better option. So if you have someone with P53 mutation, possibly offering a transplant is a good idea. If we have other risk factors like pleomorphic or blastoid morphology, possibly we should at least discuss the transplant with him. However, if we have a patient without any risk factors, and we may treat the patient according to triangular protocol, where we give BTK inhibitor during the CHOP, followed by 2 years of BTK inhibitor maintenance, then perhaps transplant is not necessary.
Let me clarify. You mentioned patient with TP53 mutation blastoid. In this patient, you will probably recommend allo transplant rather than auto transplant, correct?
Blastoid and high Ka67, I would say auto transplant. Now, the P53 mutation, it will be a difficult decision to take the patient to allo transplant in the first line. I don't think we'll find a lot of volunteers.
Let's ask to Michael Wang another question, which is, nowadays, if you meet at diagnosis a patient with a TP53 mutation, what will be your recommendation for treatment with all drugs being available?
P53 patients is really tough because they could have a high response rate, but they don't last very long. And so I really think if you're approaching a patient with a frontline and the patient does not want the chemotherapy, the best study will be the triplicate combinations that include the bovine study, the AVR study, the aberrant ventricular rituximab study. Those are good choices. But in my opinion, please remember, a lot of people think BTK inhibitors are too toxic because we use them for too long. The optimal therapy is between 2 to 3 years, but we use them for 5 years. They have atrial fibrillation. So please remember, both SHINE study and the ECHO study, if you let the acalabrutinib in the trial to continue forever, both trials stopped at 2 years. So if you use longer, you will have progression plus toxicity. So I would be careful to use any BTK in more than 3 years, especially when you have side effect. You need to stop it before it's too late. So I'm coming to the P53 mutation. I usually do after mantle cell lymphoma in complete remission after 1 year of triple therapy, 3 CR triple, so PET negative, bone marrow negative, upper and lower endoscopy with random biopsies negative, then I would put that in 2 more years of sequence maintenance that ibrutinib 280 and venetoclax 100, rituximab every other month. I really think the maintenance is very important, especially for the younger patients. That's in the front line. In the relapse setting, you don't want to try use BTK single agent for P53 mutations. And I would suggest you use as many modalities, including radiation, as you could, and move the patient to the CAR T therapy as soon as you could. CAR T cell therapy given early is more effective and most importantly is less toxic. Thank you.
So I think just if you can keep the microphone 1 second for a very quick answer. When you use radiation therapy, do you do the specific dose of radiation? Do you do adjuvant radiation from time to time?
This morning, Dr. Buthina Debaja from our center radiation chair of the lymphoma radiation gave a talk on the summarizing the radiation. The radiation, when I ever mention in my talk, is low dose radiation. We call it the bone theory. You one fraction bone, another bone, and that's two fractions low dose. When you use them with the steroids and target therapies, very effective. So my favorite bridging therapy is hypercytoxan with dexamethasone, with the delayed rituximab, with the concurrent radiation. The response is very high. Please try it if you could.
Julie, we see that non-covalent are moving and eventually moving up the lines. So there are two questions. First of all, can you readdress the question of patient failing covalent? Are you going first to non-covalent or are you going to CAR-T? And if they move up the line, how do you see sequences in the future?
I think it really depends upon your patient population you're talking about. Is it an older patient? Is it a patient who could get CAR T-cell? If they are physically and able to get CAR T-cell, I probably would do that. If they're not able to do that, then definitely pirtobrutinib is probably a better option. I think it is going to be moving up the line. You also have to remember that these patients can sometimes relapse very late. I think I was going to ask a question of what everybody's personal record is, but mine is a patient who went through an intensive induction therapy and auto transplant many years ago, relapsed 22 years later. So obviously what we have available 22 years later for that patient is different than what might have been earlier. So we continue to develop things, and hopefully we'll have many more opportunities for patients.
Thank you. I think there are many more questions regarding the role of allo in younger patients when they relapse with TP53. I think you understand that there might not be a consensus whether now we should propose to this patient CAR-T before to go to allo, or eventually in very high-risk patients discuss consolidation post-CAR-T in some places. I think there is a role of other therapies in the field, and I think we'll need another symposium on mantle cell another time.